the month of April. My name is Oluwatosin Olateju. We have the meeting materials posted online for those that are joining us for the first time. And to our commission members and the commission and the work group co-chairs, we've also emailed the materials for today. I'm going to call this meeting to order at 1:03 p.m. on April 15, 2025. So this meeting is being video recorded, just to give information about that. And by your continued participation, you consent to being video recorded. I will now call on Shane to begin with the recording.
We're good.
Thank you. All right, once again, this is April 15. We had one meeting in April, but today's meeting is very special, and I'll touch on it in a bit. But it's hosted by the Commission on Public Health. And once again, my name is Dr. Oluwatosin Olateju. I'm the presiding co-chair for this meeting. I'm joined today by my co-chairs. We have Dr. Boris Lushniak. Now, I don't know if Dr. Mina Brewster and Shane, let me know. Okay. I think she had another engagement, but she might be joining us today. But they'll be assisting with, facilitating the meeting. I'm also joined today by support staff, including Ms. Michelle Kong, Jonathan Mesfun, Shane Atchett. I want to acknowledge the presence of our special guest, John Alba, and he's the Senior Vice President for Public Health at ICF, who will be fully introduced shortly. All right, so we appreciate everyone that has joined today. It's a shorter meeting. It's going to be for 2 hours. So we're going to try to keep the momentum going. We followed the requirements of posting this meeting online, and we'll continue to do so. For those joining for the first time, our email address, you can find that online on our website. If you Google Maryland Commission on Public, we're trying to make this very easy. Maryland Commission on Public Health, you can find that. But our email address is md.coph@maryland.gov. md.coph@maryland.gov. Feel free to send us an email about your thoughts and other questions you might have. As I've said, we're on Instagram and LinkedIn. Just type Maryland Commission on Public Health. So here are some housekeeping materials. Commission and work group members, please sign in your name by typing your name and your work group affiliation in the chat box for our records. Commissioners are welcome to unmute their mics as needed to ask questions, share their comments, or participate in the discussions throughout the meeting. I kindly ask that commissioners please identify themselves throughout the meeting before speaking. So people so people online that are joining us can know who is asking the question. Thank you. Thank you for typing in, and please continue to type for all commission members. Given our tight schedule, we ask that members of the public and non-appointed commissioners send their questions to the email that I provided earlier, or note the questions in the chat box, especially when our presenter gives us presentation. I know questions might come up. We ask that non-appointed commissioner members put those questions in the chat box, and Shane will help to capture those after we have taken questions from appointed commissioners. I will now call on Shane to please conduct a roll call of all commissioners. Thank you.
When I call your name, please respond with here or present. Delegate Heather Bagnall.
Here.
Camille Blake Fall. Christopher Brandt. Dr. Mina Brewster. Jean Drummond. Senator Clarence Lamb.
Here.
Dr. Matthew Levy. Deputy Secretary Alyssa Lord. Dr. Boris Lushniak.
Here.
Vanessa Lammers for Deputy Secretary Nilesh Kalyanaraman.
Here.
Dr. Oluwatosin Olateju. Dr. Maura Rossman.
Present.
Present.
Dr. Nicole Rochester.
Here.
Michelle Spencer, Alan Twig.
Here.
We have a quorum.
Thank you. And for the record, a quorum is 50% plus one of commissioners. Thank you. So next on the agenda is adoption of the agenda. Like I said, the meeting materials can be found on our website. They were also emailed. I would now like to entertain a motion to adopt the agenda.
So moved, Boris.
Second.
Thank you.
Second.
Thank you. Thank you. Was that Jean?
Yes.
Thank you, Jean. All
Yeah.
right. So are there any discussions or changes that need to be made to the agenda? We can take a minute to note that, if any. All right. You can also type it in the chat. All right. Hearing and seeing none, we'll now take a vote. All in favor, please say aye.
Aye.
Yeah. All right. Aye.
Aye.
Okay. You can also use the hand raise button. Okay. And if there are any abstentions. All right. Thank you. If there are any abstentions or any nays, please indicate that as well, either by typing or speaking out. Thank you. All right. I do not see any. For the record, the motion has been approved to adopt the agenda. All right, we're going to move on now to the next item, which is reviewing of the minutes from April 3rd meeting. Like I said, we're going to continue to share our minutes. We're not going to show it on the screen, but you have the minutes with you. I direct your attention to it for review quickly while I take a motion to adopt the minutes from April 3rd.
Make a motion.
All right, thank you, Maura. Can I please get a second?
I'll second.
Thank you, Alan. All right, are there any discussions about the minutes from April 3rd or requests for amendments? Okay. All right. If there are none, all in favor, please say aye.
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 Okay, you can also type in the box or use the hand raise button. Any nays or abstentions about approving the minutes? Okay, all right. I don't see any. The minutes from April 3rd meeting has been approved. Thank you. We're going to go on to our special item, which is a presentation from John Albach. Thank you so much. I will give a brief introduction just so people can get to know, our presenter. All right. John Albach is the Senior Vice President for Public Health at ICF, where he serves as a thought leader and liaison with federal agencies and nonprofit organizations. Over the course of a 30-year career, he has held senior public health positions at federal, state, and local levels in both governmental and non-governmental organizations. During his 6 years as the Commissioner of Public Health for Commonwealth of Massachusetts, he developed innovative programs to promote health equity, combat chronic and infectious diseases, and support the successful implementation of the state healthcare reform initiative. He was an ASTO board member throughout his tenure and board president from 2010 to 2011. He was also previously Director of Intergovernmental and Strategic Affairs at the CDC, serving as a strategic advisor for CDC engagement with the government agencies at the federal, state, local, tribal, and territorial levels. Earlier in his career, he was the CDC Associate Director, and he oversaw policy and the agency's collaborative efforts around CMS, commercial payers, and large health systems. For 5 years, he served as President and CEO of Trust for America's Health, TFAH, where he oversaw TFAH's work to promote sound public health policy and make disease prevention a national priority through research, reports, communication campaigns, and government relations. As Boston's Health Commissioner for 9 years, he directed homeless, substance abuse, and emergency medical services for the city, as well as a wide range of public health divisions. During that time, he was a member of NATO's board and was designated board member for assisting with the planning of the annual NATO conference. Please join us in welcoming John Ardback. And please, you can use the sign button. You can, just show your expressions in different ways. I recognize we're online. It's hard when we're not in person, but what a remarkable career. I was so pleased to have you today and excited to learn so much from you. I'll now give the floor to John. Thank you.
Well, thank you so much. I really appreciate your leadership and the other co-chairs' leaderships and all the members of the commission from the work groups and the participants. I really commend you for being a national model for what we should be doing in the public health field. And it's an honor to be here today.
Thank you.
Just a few months ago, I would have given a very different presentation, though. I was accustomed to talking to people about the areas needing most attention in public health for a number of years, such as correcting the roller coaster funding of money coming in when there's emergency and going away when there's not, or focusing on the importance of building and strengthening the workforce that was aging and needs new skills and connections, and thinking about working upstream on social determinants of health and equity, and not simply particular disease-specific approaches. But while these are still really important issues, and I'm sure you've heard all about those from others, they now seem less pressing given the urgent need to adjust to the dramatic federal reductions in funding and staffing. So my presentation today is focused on some thoughts about how to adjust to this new reality while retaining a focused look on the ways to optimally promote the health and well-being of the American public. Next slide, please. Just before beginning, I would just say that while the scope of the present reductions in funding and staffing can seem overwhelming, it may be helpful for just a split second to reflect on the fact that there have been many other trying times in public health. I'll just give the example of in 2008 and 9, during the recession, I was the Massachusetts Health Commissioner. And during my 6 years in that role, I oversaw 8 rounds of budget cuts and layoffs. Each of them took months to complete. I never had a month that I wasn't laying someone off or cutting some program. And yet we figured out ways to continue the work and to adjust. Now, thinking about the past responses to crisis in no way diminishes the magnitude of the current pain, but it just may help to recall earlier crisis and the fact that there's strength in the public health professionals and advocates who are mission-driven, resourceful, and resilient. So next, please. So I tried to think concretely about a few points to highlight in the time that I have. And I thought that I would focus on 6 areas where the commission might want to pay some attention given the specific and pressing circumstances we face. So I'm just going to quickly go through each of those. Next slide, please. The first priority is protecting and enhancing public health data. The availability of health-related data is just key to public health, and it's been that way since the John Snow days when public health began. Since there may be less data from the federal government in the future, we don't know the specifics now, but it seems that it may be the case. It's especially important for Maryland and other states to consider how to ensure it has the data to protect the public. And in this regard, it makes sense not simply to consider the traditional core data sources, although they're important, of course, but it also means seeking data from new sources, such as the opportunity offered by wastewater surveillance and the use of AI and other innovative tools that may deepen our understanding and provide insights more quickly. And the other piece I'd emphasize, I'm sure you've heard of before, is the importance of gathering data from healthcare as well as non-health related sectors such as housing and transportation. And much attention.
Did John freeze?
Yes, it appears so.
Oh, gosh.
We lost you for a second there.
Am I back?
You're back. Yes, you are. Thank you.
Okay. I'm so sorry. Well, go to the next slides, please. please, if you don't mind. The second priority I'd highlight is deepening the ties between public health and the communities being served. That is the residents of the communities, local organizations, local leaders, particularly those who otherwise lack a means of input. Public health has been uneven in this work, and I say that with an acknowledgement that I should have paid more attention to it during my public health work at the local and state level. And to deepen these ties, there are a number of steps that can be taken, such as assigning staff to do community work, specialized staff if possible. Although I think it's important to consider whether almost every member of the staff can have their workload adapted so that they can have some component of their work that puts them in touch with the communities at greatest risk. I think it also involves it also means involving community members in policy and planning decision-making and not just advisory issues. So this is creating meaningful roles for community members in shaping the agenda. Hiring from the community, for example, community health workers, is also a part of this, as well as doing the difficult work of figuring out how to channel some of the resources to the grassroots level and the grassroots organizations. Next slide, please. The community ties about building with partnerships, which I was just mentioning in terms of the grassroots level, are more important than ever because our field is under attack, and partnerships represent a broader sense of partnerships, represent my third priority. These partnerships for this particular priority involve other sectors, people in the healthcare field and in non-health sectors that include housing, jobs, transportation, and employers. Here too, the key may be assigning specific staff to specialize in those relationships, really come to understand those other sectors and work closely with them, not in a superficial way, but in a meaningful way. I know as someone who tried to do this as a state health commissioner, that's not easy, but it's doable, and it can produce really valuable outcomes. We need allies now, and we don't want to find ourselves standing alone when under attack, but we also want to strive to alter the environment and the social conditions so that the easier behavior in general in people's lives becomes the healthier behavior. Next, please. The fourth priority is focusing on the conditions of greatest importance to the community rather than focusing attention only on the ones that have special line item funding. My own experience for decades at the local, state, and federal level was that the issues that got addressed were the ones that were funded. And even when there were really important health issues to the community, if we didn't have funding, we just didn't pay attention to them. And we just can't afford to do that. So I'll give an example. There's a rapidly growing population of older adults and people with disabilities, many with significant public health concerns. But because of the lack of specialized public health funding, the public health sector has done relatively little with these populations. I used to do annual meetings in states where I would say to folks, here's the changing demographics in your community. How many of you are working with older adults in a specialized programmatic way, not just the seasonal flu vaccine? And no one raised their hand. But when we broke for a reception and I would be talking to people about what was happening in their lives, everyone would talk to me about, oh, they were trying to get their parents to be able to stay in their home, or their spouses or family members. They were clear that these were important public health issues, but the work didn't focus on it. And even if we lack adequate funds to do this kind of work, we can use data, communication, we can develop partnerships, and we can use the bully pulpit to draw attention to them. Health agencies should determine the key issues through a collaborative process that involves both the data collection I was mentioning earlier, as well as sophisticated analytics, and listening to the voice of community members themselves. They often will say things unexpected, I've learned through my years of doing this, and paying attention to that's critical. The attention to grassroots and other sector partnerships mentioned above will help in this arena as well to determine what these priorities should be. Next slide, please. The fifth priority involves supporting the workforce. And here I'm talking about really striving for the workforce to have competitive, livable salaries and benefits and career ladders, as well as paying attention to their safety, something that's a growing problem. We also need opportunities to applaud and celebrate the members of the workforce. When we face a situation now where budgets are cut, often training and conference attendance are the kinds of things that get cut right away. But that would really be unfortunate because those kinds of things can strengthen and encourage the workforce. We just won't be able to attract and retain the best and the brightest if we don't think seriously about how to make our work environments supportive and attractive. And finally, next slide, please. We need to prepare for the spark. And by that, I mean the opportunity that will allow public health to demonstrate its importance, restore lost funding and lost staff, and grow. History would tell us there's gonna be a spark. It's coming. It might be the result of a major threat to the public. It could be a novel virus. It could be something environmental. It could be terrorism like we faced in 9/11. We've just seen one of these after the other. And right now we're shrinking. We need to, at the same time, be prepared for how we're going to grow rapidly in response to that need. We need to get ready. We need to make plans, do trial runs, tabletop exercises, and consider the skills we'll need to respond effectively and immediately. Even while cutting, we need to prepare for growing again. And we should do that not just restoring things to the way they were. We need to be well prepared to promote the vision of what the sector needs to be. So I've kept my comments brief because I wanted to leave time for comments and questions from members of the commission. But I would just say in closing that if any state can prepare for the future and build a strong public health department and vision, it's Maryland. Your track record's impressive. You've shown the way on lots of issues, from hospital reimbursement to harm reduction, from building linkages between public health and healthcare, to creating this commission whose members are in attendance today. Given the remarkable progress that you've undertaken just through this process, I suspect that nothing I'm presenting hasn't already been considered. And I look forward to your final report and what I hope will be the support you receive for implementing your recommendations. So thanks very much for the opportunity to share my thoughts. I'm happy to engage in conversation now or to talk offline with any of you in ways that would be supportive of your work.
Thank you so much, John. Thank you. I mean, listening to your presentation, it reflects, a lot of the things we've been talking about, including some of the things we were charged, to do as a commission, where, be it looking at strengthening the workforce, improving our data collection, improving our partnerships and community engagement and communication. In fact, all of those things are all embedded in the work groups, that are represented in this commission. So thank you so much for your insight. I think one thing stood out, one of the last things you said, which is preparing for the spark, right? We need to show, the opportunity. We need to take on the opportunity to demonstrate our importance in public health, to demonstrate our value. And, so I think this commission, hopefully, our OPES will serve as a model, for other states to take on this work. Thank you so much. I'll now, open the floor for other comments or, from our commission members. Thank you once again. Thank you. Yeah.
Boris?
Yeah, John, thank you so much. Great and to the point conversation. One of the things that we've had discussions here at a commission level is, trying to come up with these recommendations. We're kind of in that phase right now. So, this is a lot of work, a lot of lift now. after having multiple perspectives given to us, we've had multiple presentations, great people coming in, such as yourself. We have our working groups submitting their recommendations. We are now reviewing them. Then we'll have de novo recommendations coming from members of the commission and others. So the process is now sort of in its last stages. But setting that environment, right, which is not only the environment you described as an existential threat against public health in general, but in essence, the budgetary constraints that come with this, not only at the federal level, but we all know also at the state level, right? The state of Maryland, had a $3 billion deficit it had to deal with this past year, so that we aren't talking in this fiscal year coming up, a land of abundance. With that environment set, how would you sort of recommend to the commission, right? When we look at our recommendations, how, from your long experience at also made level, how aspirational should we be, right, in the midst of this versus the idea of the practicality of the current environment? And we all have our feelings on it, right? But I do want to sort of get your viewpoint, because I do respect you and your public health vision. Over.
Thanks. I think that's such an important question, because you don't want to issue a report that just falls flat on its face or just ends up on a shelf. And so really struggling with how to balance the aspirational goal with the practical realities. I think my inclination might be to say to be aspirational in terms of the vision, in terms of the North Star, in terms of what's needed, and what you've heard will truly make a difference in terms of the health and well-being of the people of the state. At the same time, I think it would be, it might be wise to acknowledge to policymakers and to the public that we are in an unusual and extraordinary time period where we are not able to move ahead in as rapid a way as might be wished for in terms of that aspiration, and that therefore there needs to be some notion of in the short term what's necessary in order to protect the health of the public. So in other words, I think I wouldn't give up that aspirational vision, that North Star, but I might suggest fully acknowledging the difficult time and offering some interim thoughts and recommendations, not as endpoints, but as actions that can be taken in a practical way in the coming months and perhaps years, but never losing that aspirational vision.
Great, thank you, John.
Jean?
Yes, I just wanted to say thank you. I thought it was a couple of good things that I really appreciated. And first of all, just the transparency of your statement around how you would have given more to the community. If I ever had time to get a PhD, I would talk about the value of community, our zip codes, and value-based care and payment, right? And so I just really appreciate in all of your expertise, the transparency. So I do want to say that. The second thing that I would say is the resiliency of this workforce, of this work. I mean, we are public health. We are the population. And I mean, as professionals, whether you're in it or not, we are it. I was on a call earlier today and they were talking about the spread of measles. And the conversation was, well, it's not in our area yet. I'm like, okay, what day do we need for it to show up in your area for there to be concern, right? So I think I appreciate that, and we are resilient because this is about us. But then I also love Boris's question of, okay, so we tend to do it. We have a bounce back factor, but how low do you get before because as you said, you get funding, because I remember many times that you get funding for, I don't know, cervical cancer. And so all you're thinking about is the woman's, female organs. Well, what about her mental health, right? And how do we serve in a holistic kind of way? So I don't have the answers, but I do appreciate just the transparency and the thoughtfulness that you have shared with us today. Thank you so much.
Well, thank you. And if I could just maybe respond to the first comment you made about the community and the community ties, and the fact that I was saying I didn't do a good job. I think that that's an area where there are very specific steps that can be taken. In the last few years, particularly when I was at CDC and since then, I've really worked with other people who have done that work well to come up with concrete and specific steps that can be taken that really overcome the historic obstacles that have been in the way of developing those ties and channeling resources and involving community in decision making. So I think that and I'm happy to share some of those with commission members if you like. I think we've got now some really very positive examples of where people have tackled and overcome those historic barriers to strengthening those ties, and they're worth pursuing.
Great. Thank you.
Nicole?
Oh, I apologize. I did not mean to have my hand up. Thank you.
Looks like those were all of the hands that were raised.
Fantastic, wonderful conversations. Thank you so much. All righty, we'll move on to the and I see some claps coming in. Thank you once again. I see next item on the agenda is the recommendations review and discussion. All right, before we get started on this, there are also some housekeeping things to note on this, right? But before I get to the housekeeping, I want to just make a statement about the steps it's taking us as a commission, right, to get to this point. It has been a lot of hands on deck. It's been a lot of work. We really commend our academic partners. We commend all the work groups, all the work group co-chairs, the members. They've worked tirelessly day and night to come up with these recommendations. So it's not been, we didn't get to this process just overnight. And just like how we do in public health, even it's like, testing research, you test your hypothesis, right? So a lot of this is we're learning, there wasn't any like model for this work, right? We are learning as we go here, right? And so, and we want to just acknowledge your patience, we want to acknowledge your support that has gotten us this far. So we have, in the last couple meetings, we've gone through some recommendations, but that process has also allowed us to refine, just our processes around this. So today, we are keeping the same slate of recommendations of actions that we'll be voting on, the actions rather, which is to advance slate, recommit to work group, or cannot support. And you will see it on the poll. But before we get there, I want to direct your attention for the commission members now to the email that was sent out with the poll details. You're going to need that. And I will share my screen in a few minutes after Shane has gone. So we want to direct attention to that. There's a QR code there that you can scan. You can get into it now. You can start playing with it. And also you can text the code, or you can, you can copy the texted code also, or you can use an app, whichever one works. Now, the materials that were sent out for the meeting also includes the list of the recommendations. Now, for the full set of meeting materials, the recommendations that we are voting on today are the ones highlighted in green, right? Shane, can you just show that briefly? If you just advance to that, I just want to make sure we're just advance. I think it's on, it will be on slide, it's on slide 8, I believe, yeah. Sorry about that, yeah. Yeah, slide 8. Yeah, so it's gonna be the ones that are colored in green. Now, we also sent out a separate attachment, right, called prep sheet for commissioners. It has all the 10 there, right? So this for the meeting materials, we are only voting on the ones in green. We have listened to everyone in terms of, just being more transparent. Everything we've gotten to date is on this document. However, if you look at the legend there, we're only voting on the ones in green, just to, to draw your attention to that. So, but if you look at the prep sheet, everything on the prep sheet, which is a separate document, is what we're working on. Okay, so now let's please go back to the 3 sets of recommendations, just so that in case we have any questions about that, and then we'll proceed. So I think that should be the previous slide that was shown. The way this is going to go is we will show the recommendation that that you guys have. We will show that, but we're only going to be looking at the recommendation name and the description, because commissioners have had an opportunity to review this. The document is also hyperlinked, so you can click into it to read the details. But at this point, we are almost assuming that everybody has had enough time, right, to get into the weeds of the details of each of the recommendation. So once Shane projects the recommendation on the screen, we will have, once he describes it with the name and description, we will have 2 minutes for discussion per recommendation. And then after that, we are going to follow up with a vote. So we will be juxtaposing between Shane's screen and my screen. I know it's going to be, but because my screen will show the poll results, right? So, but I will let Shane get started with the first. So thank you. So 2 minutes per discussion once it's shown. Thank you.
The first recommendation is FND 007, advocacy for federal grants with longer durations and more local flexibility. The funding work group submitted this recommendation that MDH staff should advocate for longer 3 to 5 year federal awards, be given the preponderance of chronic disease problems addressed by the 21st century public health agencies at state and local levels. A multi-state coalition of state health agencies, along with NACCHO, should push Congress and federal health agencies to reassess the time frame of grants. Advocacy should also work toward less prescriptive grant conditions that acknowledge differences in socioeconomic and cultural conditions across and within states that drive health outcomes. For example, the underlying factors that result in maternal mortality, cancer incidence, or overdose deaths vary across regions and need more flexibility in grant use to match the dollars to needs. They noted that this is proposed as a short midterm project that would likely require several years of effort due to the need for cooperation by out-of-state entities. Legislative action is not required since it can be accomplished through advocacy.
Thank you, Shane. We'll now take 2 minutes. As you can everyone see the timer on my screen? If not, can you see the timer or no?
No.
No? Okay, good. I'm going to share my screen now, and you will still be able to see the, let me see. You'll still be able to see, let's see here. Okay. Can you let me know if you can see my screen with the poll and the description? Yes. Okay. Awesome. Thank you. So this is in a nutshell what Shane just read. So please continue to submit your votes. And the timer is on 42:11. So we will stop on what is it? 40? Sorry, excuse my math. 44. Yeah. We'll give enough time. 40. I'm sorry. How many minutes should we take for the votes? Is there? I know we described for 2 minutes. We can take a minute. Is everybody okay with a minute? Just give thumbs up.
I think I'm going to need a bit more time to get into it.
Yeah,
Yeah.
I'm also gonna need a little more time.
Okay.
Yeah, I'm trying to get in myself.
That's fine. That's okay. Fortunately, we've
Oh.
set it up for enough time. You can see the timer there. I think it has enough time. We'll just give people more time to advance, and you can see there as people are submitting. Yes, please, Alan.
Yes, and we may not need it for this, but just thinking about an opportunity for any discussion before we open the poll for voting.
No, I think that is great. Thank you. That's acknowledged. Do we want to discuss? Yeah, please. And that's a great point, Alan. And people can change their responses based on. So let's have discussion, and then if based on the discussion, people can change their responses, and then we'll follow that accordingly for the next set of questions. Thank you. So any questions or comments or?
Tosin, just a point of order, so folks are fully aware. I wanted to confirm that on the back end of this, you do have the individual voting data, so we can verify that for folks and validate these selections in case there are any questions or concerns about that. Correct?
Yes, absolutely. Yeah, thank you. So please make sure that as you're completing it, you put your name so we know who's completing it. Thank you. And I'll stop sharing for a second so I can submit my votes as well.
Vanessa has her hand up.
Yeah, please go ahead.
So question on this one. I think this one really specifically mentions MDH staff advocating. And I think, in governmental public health, we often rely on our non-governmental public health partners and our associations and our national organizations to do a lot of the advocacy work for us and in partnership with us. Because in government, we may or may not have the ability to do quote unquote advocacy or lobbying, right? We can do education, can support, but there's a little bit of nuance here. So just wanted to mention that.
Thank you, Vanessa. Any reactions to that? How many of the members?
Nicole?
I don't have a reaction to that, but I'm finally at my desk and noticing that I don't have access. When I try to click the hyperlink to see the additional information about the recommendations on the prep sheet, it's saying that I don't have access to the document. So I'm not able to see. I don't know if this applies to anyone else on the call, but I'm looking for a way to see the entire recommendation beyond the short description.
The agenda materials have the completed recommendation. I can resend that to you if that would be helpful.
I have that. I'll just keep scrolling. I wasn't sure if it was in the. I'll keep scrolling. Thank you.
Mm-hmm.
Thank you. Are there any other comments or discussions around that? I am going to reshare my screen. I'll just also give people the time to all right. It looks like we have it looks like the motion carries, right? And again, I want to just make sure that we emphasize that these are not the final, right? This just means that it's advancing, right? We have the most selection, which is the first, which is to advance to slate, right? And that means submission is approved to be considered for the June 5th recommendation slate. So we're going to have another meeting in June 5th. All right. Moving on now, we're gonna go to the next. I'm gonna stop sharing and have Shane share to read the second. Thank you, everyone. So this one moves on. Thanks. And please bear with us as we just oppose between different screens, but this is public health.
Tosin, I'm sorry. This is Matt Levy.
Yeah.
I have a quick question. I was away last week, so
Okay.
I'm just catching up. These are going to the who are these going to, and why are we putting these in? Seems like we're taking a step in a more legislative direction than we were.
Are you asking in general of all the recommendations, or the one that we just took a vote on?
Well, the one we took a vote on, for example, where is that going?
So it means that we're going to, it's one of the ones that we are definitely going to be having on our final report, right? So it's moving on to the next slate. In June, we're going to have to take a final vote. But all of this, because we have a lot of recommendations coming in, we don't want it to be a one-step process, right? That's my understanding. So we want to get the ones, at least get some forward, right, towards almost the full approval. And then during the June 5th meeting,
Okay, I
take
got
the final vote. And Shane or Boris or anyone on the call, please, you can correct me if I'm wrong.
Yeah, what I would add there is we recognize that reviewing the recommendations on a rolling basis does not give us the chance to consider them in totality. So what this process does is essentially triage the recommendations into these different categories so that once we get to that June 5th meeting, we'll have an opportunity to more fully consider what gets advanced to the draft slate that is published for public comment. So that's why it might seem like it's a bit legislative in nature at the moment, but that is by design so that we're not necessarily committing to everything as is, but reviewing things as they come in to give work groups feedback on where there may be potential concerns, while also moving things forward that, at least in concept right now, are things that the commission feels they could support, but we'll have that kind of final say in terms of organization and refinement at that June 5th meeting. Does that help clarify?
Yeah, that definitely clarifies. Now I'm reoriented after vacation. Thank you.
Welcome back. Tosin, it looked like there was someone who did say that they could not support on that last one. I didn't know if, for the work group's sake, if that would be helpful for them to know perhaps rationale, or if it's fine as is, but I at least wanted to flag that for potential discussion.
Yeah, I think that's a good point. Can we please have the person that said they couldn't, can you please indicate and please express the reason? So, because these are also opportunity, it could go in the final report as areas of future exploration. So the fact that something goes to the cannot support box doesn't mean it's totally ruled out. So please, whoever completed that, kindly share some insights about that. Vanessa, please.
Hi, Vanessa Lammers. I'm representing Deputy Secretary Dr. Kalyana Raman today, and MDH opposes this as written.
Okay. Thank you. Do you have additional information about your position, or?
I think there's sorry, we're still talking about the previous one, right? The advocacy
Yes,
for federal
the
grants.
previous one. Yeah.
Just to clarify.
Yeah. No.
Yeah. So I think a variety of reasons having to do with this being a delegated function to MDH staff, and the realities of MDH staff being able to do advocacy as defined, and then the existing federal landscape, and is MDH able to Is this an effective use of time that would be able to reach this goal right now?
Thank you. Thank you so much. All right. We will move on to the second one. I think Shane just shared it on the screen. We'll go back to that. We will, going by Alan's suggestion, we will take discussion on it. So I won't open the poll now. Once the discussion is set, after 2 minutes timer, we will take the poll. I will also encourage that we take the poll for 2 minutes to give people time. All right, so 5309, please. Sorry, Shane first read and then we take the discussion. I'm sorry.
Thank you. The next recommendation is FND 008, Medicaid reimbursement equity from the funding work group. The recommendation reads, Medicaid reimbursement for local health department and Maryland Department of Health should equal Medicaid reimbursement for federally qualified health centers. Like FQHCs and unlike private medical practices, the majority of local health departments and the Maryland Department of Health healthcare facilities payer mix is comprised of Medicaid recipients. Equivalent higher Medicaid reimbursement to public health providers is needed to compensate for the equivalent degree of medical complexities and no-show rates that accompany socially high-risk, low-income populations. They also noted that this proposed recommendation could be implemented in the next 1 to 2 years. It would require legislative action and certainly have an impact on the Medicaid reimbursement appropriation.
Thank you so much, Shane. We'll now take discussion for 2 minutes. I will share my screen for the, it's 1:55 now. So when it's 1:57, we'll take the discussion and then I'll share my screen to show the poll. So are there any questions about that? Maura, oh, she said she doesn't see the poll. I can share it now, but I won't open it yet. I just want to make sure that we give people we give people time to look at it and all that. So let me, yep, that's it. So Medicaid reimbursement equity. Sorry, can everyone see my screen? I just want to make sure. Yeah, okay. Medicaid reimbursement equity. That's really what it is. And then I'm trying to hover on it. Can you see the while I'm sharing my screen, I can't see people in the room. Can you see the description when I hover on it? Can somebody let me know if you can see the description when I hover on it?
Yes, I can see
Yeah,
it.
okay, thank you. All right. So yep. So
also
if there are questions about that or discussions, we can take that for a couple minutes, 2 minutes, and then.
Did I miss how we get to the next poll?
No, I'm going to open it. We just want to make sure that, no, I haven't opened it yet. We want to make sure that people ask their questions, that we have a discussion about it before we open the poll up. So if there are no, and it was on at 1:57 mark, if the timer is 1:57. So I just want to make sure. All right, the timer is now 1:57. So the poll is open. All right.
Nicole, you have your hand raised?
Yes, just a minor point in terms of language. We may want to consider putting many in front of unlike private medical practices. Of course, this kind of makes it seem like there's absolutely no private practice that has a majority Medicaid. And while I certainly appreciate that that's not a great financial model, I think there are a few examples of that. So we may just want to add unlike many or most private medical practices.
Thank you.
We can make sure that the funding work group co-chairs note that. And I think I saw Gina and Dr. Polsky on as well.
All right. I'm purposefully not showing the results, not to skew people's, that's why I scrolled up a little bit. We'll just give people time. I'm also going to complete mine. I'm sorry, did you say we had more questions? Sorry about that. No? Okay, all right. Make sure. Okay. All right. That so at 1:59 will be our 2-minute mark. It's 1:58 now. We have 1 more minute for people to submit their poll on that. Oh, actually, I thought I could scroll to not show the votes, but I can stop sharing for a second. Give people time to vote, then we'll pull it up. Boris, you have your hand raised?
Yeah, just a question. And this may go to our work group co-chairs. The question is, does any other state do it this way? Do we have any models like this, or is this a novel model?
Boris, to the best of my knowledge, this would be a novel thing. And I'll just throw in there that this would be a very, very modest increase in Medicaid expenditures. We'd definitely be in the very low single digits because it's not affecting hospital care other than psychiatric facilities that the state runs. And as people on the work commission may know, we just got a significant cut in Title X funding last week. We're running into realities that if local health departments can't collect better on patients they see, that we may be in jeopardy of folding up entire programs.
Thank you.
Okay, thank you, Larry.
All right. We just want to make sure that everybody please submit their votes. You have 3 options to select from. That way we can go on with the next, please. And if you're having trouble accessing it, let us know. We can resend it.
Vanessa, did you see my response to your question?
Yes, thank you, Shane. So for this particular recommendation, we would like the Deputy Secretary for Healthcare Financing and Medicaid to weigh in. I think we can get that perspective and go from there. So abstaining for the moment.
Abstaining, okay. All right, thank you. Okay, so I think we have the majority there as far as the second one. All right, so 7, 8, and then we have 1 abstention, so that's 9. We have, yeah, and for totality counts. So yep, so that carries. Thank you so much. I'm going to stop sharing my screen. I'll let Shane take the next one, which is the 3rd. Okay.
The next recommendation is FND 009, local health departments as quasi-governmental agencies. The recommendation from the funding work group is to create a quasi-governmental structure for local health departments similar to the Health Services Cost Review Commission and Community Health Resources Commission. This could allow for more flexible human resources policies that better match public health needs, new modes of fundraising that are analogous to private nonprofits, and profit-generating entrepreneurial projects such as daycare centers for working families or similar. Profits generated from these efforts could be reinvested in local public health work that cannot be financed through traditional funding sources. This is proposed as a long-term project that would require additional considerable study, and we will now entertain discussion.
Thank you, Shane. Vanessa?
I have seen this idea of HSCRC being quasi-governmental, I think, floated throughout. I just want to clarify that HSCRC is a state agency. It's a fully governmental state agency in Maryland. and it does have some independence from MDH. So I'm not sure if that's where that confusion may be, right? But it's a fully governmental state agency. The other commission mentioned is the commission with 11 appointed members from the governor's office. So it functions almost identically or similarly to our commission here. So just want to mention that.
Thank you, Vanessa. Are there any other comments or discussions around that? Maura has her hand raised. Thank you, Maura. Please proceed.
Hi, I'm just gonna say, maybe the wording can be changed, but in its present writing, I can't support this. I think there needs to be a lot more research, just like some of the comments that Vanessa said, as well as potential, a SWOT analysis, if you will, that hasn't been done. If it were posed as a study, I see the little descriptor at the end, then I could be on board. But as presently written, I can't.
Thank you, Maura. All right, I think we're on. Oh, I'm sorry, Nicole, please.
Hi, yeah, my comments are aligned with Vanessa and Maura. I also don't feel that I can support this in its current state. I feel I acknowledge all of the concerns and the rationale for the recommendation, but I feel like there are other steps that we can take ahead of creating an entirely different structure to accomplish these goals. And I think that we can make recommendations and there are, I think, other recommendations that have gone forth that speak to the challenges with funding and some of the other things that are addressed in this recommendation. So I also would not be able to support it.
Thank you so much. Since I want to make sure that we still have quorum, we're gonna go on to the next vote. But Shane, can you just eyeball? And that would be a 9+ for commission members. I'm sorry, for commissioners. And I know Vanessa is representing the LESH. Do we have any other person representing the ex officios in the room?
We have, I counted 8. Our quorum is 8 since we only have 15 appointed positions.
15. Okay, perfect. Okay, thank you. And for the previous recommendation, yeah, we had quorum for that as well. All right, thank you. I'm going to now open up the poll for number 3. So please go ahead and submit your responses. For funding 009. And we will give it 2 minutes. It's 2:06 now. So at 2:08, we'll give it 2 minutes. But if we've had majority of the votes, yeah, if we have 8, then we will move on. I'll just give it a few more minutes in case people want to change their minds. All right.
Can you share your screen, Tosin?
Sure. Sorry about that. So this is what we have. So the majority of the votes is on, well, it ties between recommitting to work group and not supporting the so this is one of those ones that we probably have to bring back up. And, I welcome thoughts and suggestions on that. Okay. So the poll is now, okay, we have 1 more minute.
Just shifted.
Yeah, it just shifted. It closes at 2:08 anyway. So people can still change their minds. 1 more minute. All right, the time is now passed. So recommit to work group is what majority selected. All right, thank you. All right, I'll stop presenting. We'll take the 4th one.
Dr. Polsky and Gina, do you feel like you have enough on that from the discussion to rework the submission?
Yes, we realized that that was a very, shall we say, aspirational kind of recommendation. So, and to Mara's point, it was not meant to be, this should happen in this form. Again, it would probably take a lot of discussion. So we can take it back to the work group and see if there's interest in reshaping it.
Yes, agreed.
Excellent. The process is working. Thank you for that.
Sorry, I didn't realize I was on mute. We'll take the fourth one, please. Thank you.
Sorry,
Yeah,
I'm sorry. Was the vote? So that was the final poll to recommit
Recommit
to.
to- yeah. Mhm.
Okay. Thank you.
Yeah. Thanks.
The next recommendation is FND 010, Public Health Business Advisory Board. The funding work group recommends partnerships with Maryland businesses, provide new opportunities for public health funding streams. As a result of preventable somatic and behavioral health problems, Maryland businesses lose significant amounts of money to workplace absences, poor productivity, workplace errors that result in injuries and lawsuits, employee turnover, and higher health insurance premiums. The goal of establishing a public health business advisory board would be to prevent public health problems such as diabetes and substance use disorders that lead to higher employer costs. We will now entertain discussion. Nicole?
I love this idea. I was struggling to see the connection to funding, but I see on the second page, it says employers could fund public health initiatives. Could somebody from that group maybe provide, just for my own education and maybe helpful with the group, what would be the mechanism by which employers would fund public health initiatives?
And so I think that would be something that would have to be developed with the advice of attorneys and other people that we don't have represented on our group. But the idea would be that we would start with a core group of businesses and identify what is most important to them. It could be, for instance, alcohol misuse that could be leading to significant problems. The businesses themselves would put up either all or the majority of the funding that might be matched through other mechanisms. And then, yes, we would need some kind of repository for those funds to then be channeled to public health agencies to partner with the businesses to develop programs that would go into prevention, in that particular instance, behavioral health interventions.
Thank you, Lawrence. Is this something where like someone from the governance would be able to possibly add to that from the governance work group? I'm just trying to understand the structure for how, like, is this feasible? I love the idea of an advisory board, regardless of, but I'm trying to put it in the context of funding and how it will directly contribute to increased funding.
Yes, well, the idea, and I see Mara put a comment about insurance companies. The idea is that, a lot of public health work is the people who benefit financially are not the public health agencies. In this case, the businesses, in the case of alcohol misuse, there's the direct costs of treating alcoholism are relatively small compared to the economic losses from businesses. So businesses profit, and then to Mara's point about the insurance companies, it also saves money for insurance companies as well. But the idea is that it shouldn't be just on the taxpayers, that the businesses and perhaps the insurance companies who profit off this should be kicking the money in to fund at least the bulk of this. That's the funding connection with this.
I see that Dr. Levy also has his hand up, and Dr. Rossman raised her hand as well.
Thank you.
Yeah, I like this idea overall. I think it speaks to the pocket problem, which is savings in one sector doesn't translate to another sector. So savings in the health system doesn't necessarily translate to the social service or public health system. I would only suggest maybe that you add in the health systems and the insurance companies into this business advisory board. I didn't see them listed, but they have to have some skin in the game on this, I think, too, because it would save the whole system money, and a lot of that money is being saved by them. So that would be my suggestion on this. I like the idea though, because I think it is important to bring, this is more of a holistic approach or a multi-sector approach to public health, which is really what we should be doing in the first place.
Thank you, Matt. And I know Maura has a hand raised, and then Boris.
Yeah, agree. Similar to what Matt said, this is not about, who's making money and who's losing money. It should be about how, particularly how to make people healthier, right? And right now in Maryland, we have a healthcare system that predominantly is managed by the insurers. It's not by businesses, it's by insurers, and then also hospitals who take care of very sick people. So maybe send it back to the work group to maybe change the language so that you're creating, I think Matt used a holistic approach in engaging those who work on sick care, right? The insurers generally, as well as the hospital, that they must be also partners with public health, which I'm going to just put in the preventative care.
And that's well taken. I just want to again emphasize that the majority of the savings is not to insurance companies. The majority of the savings is directly to businesses in increased profitability, increased productivity, decreased employee turnover. Those are not decreased employee turnover is not costing an insurance company anything. It's costing businesses a lot of money and time and administrative cost. So again, I'm speaking on behalf of the funding group and the discussions we have. I think it's reasonable to add insurance companies in, but the bulk of the money that would finance this is going to come from direct increased profits and productivity from the businesses themselves. It's not, again, the cost of treating alcoholism in an ER. It's the amount of increased productivity for those businesses when you have people who are no longer coming in under the influence or no longer have to be fired, after 2 months of employment because they're not showing up for work.
Thank you, Larry. We'll take one more question from Boris, and then we'll close discussion. We'll go on to Paul. Thank you.
Larry, just a clarification. Where is this business? First of all, I like the idea. Where is this Public Health Business Advisory Board housed? Has the work group sort of looked at that?
Well, so we have not consulted attorneys. I think that really, it would come down to how can the money be shifted from, if you have, let's say, 3 large employers in the state, Under Armour, Amazon has a huge warehouse. If they're interested in this, how does the money get from them to public health agencies? That's a question we have not delved into, and I think that would then answer the question that you're asking.
Okay, thank you.
Thank you, Boris. All right, we'll now move on to the poll. We're going to open the poll up, which is for funding 010. So please go ahead and make your selection. Thank you. And I will share my screen after that, once people have selected. Thanks. And I think we are doing well with time, because, yeah. We'll take up until 2:19 to close the poll, so you can make changes as needed. Then if I've seen the majority have selected, then we'll go ahead to close it. But we'll still honor the time in case people want to change their mind on this. I will share my screen now so we know where people are leaning towards, since we have 8 responses on that. Okay, yeah, and that's still a quorum. So this is what we have right now. We have a quorum, but I will, we'll leave till 2:19. So that in case people want to change their mind on that.
Is someone abstaining? Is that why we only have 8?
Well, there's no option to well, okay, yeah, if they want to abstain, yes, sorry. But we really would prefer that people pick from the 3 selections. I know we had the recommendation number 2. Sorry, Boris?
We're up to 9.
We're up to 9, yeah. So we're good. And we'll give it a minute. I know recommendation 2, we had 1 abstention. Yeah, otherwise, yeah. Excuse me. All right, it's now time. The poll will be closed. All right, thank you. And most people said advance to slate, I believe. Yeah, the large majority said advance to slate. So it's going to go on. And yeah, thank you. And I just wanted to note that if something goes to advance to slate, we have till June 5th. Within the work groups, there's always that discussion of, before June 5th, right? What can we do to make this better based on the feedback? That's why, so we don't want this to be misconstrued that if something goes to advance to slate, it just gives it more power to move on. But then at least knowing that all of those feedback can still be incorporated. All right, I will close the poll now, and then we'll move on. Shane, please present the 5th one. Thank you. So we had majority take advance to slate. All right.
The next recommendation is FND 023, Streamline Health Insurance Carrier Contracting Process. This was submitted by the Funding Work Group, and it reads, the Maryland Department of Health Secretary shall delegate authority to local health officers to enter into contracts with health insurance carriers once contracts are approved in writing by the Attorney General's office or the respective county attorney's office. Review for legal sufficiency of all such contracts when requested by local health officers shall be the responsibility of the Attorney General's office. We will now entertain discussion.
Thank you. And it's 2:20. We'll take up until 2:22 for discussion. Thank you. Maura has a hand raised.
Yeah, I don't understand this one, so can someone explain it? Because at Howard County Health Department, we do our own negotiations and contracts, so I don't understand this.
Yeah, so currently before a contract can be executed, every local health department does need to get a sign off by the Secretary of Health. Now, in the past,
I don't do that, just saying, so.
Oh, okay, well, Gina, if you want to jump in, but my understanding is that's required.
I didn't know about that policy. Apparently several years ago, I think under Secretary Scharfstein became a secretary's protocol where we have to get permission from the Secretary of the Department of Health prior to contracting with a healthcare contracting entity. And this is coming about because of problems that I've brought up repeatedly. We have been trying to contract with Blue Cross Blue Shield for about 8 years now. They give us arbitrary 1-week deadlines. They refuse to sign contracts. I got involved about a year ago, and we have not been able to contract. We're losing money. They delete our credentialing. They say you have 1 week to respond. We can't get the secretary's approval within that 1 week. They don't like our contract. They want different terms. And even though we've got that contract approved by the AAG, they're still not signing. So that's where that's coming from. I just did my most recent reiteration of it. I sent the secretary's protocol back to Dr. Kalyana Raman yesterday, because I understand he now has been delegated from the secretary to be able to approve those. So I'm just waiting on that so that I can attempt to get Blue Cross Blue Shield to sign the approved contract. So that's where that's coming from.
Thank you. I'm sorry.
It's not your fault. It's just very frustrating.
So it's a relatively minor, this is a more of a technical issue. but we felt, and Mina Brewster had chimed in on this one as well, advocating for this, that it's an unnecessary bureaucratic step. But we also want to make sure if the secretary is not going to be a necessary signator on this, that for counties who they can't go through their county attorney, for local health departments can't go through their county attorney, that the AAG still has a responsibility to review the contracts for legal sufficiency.
Thank you. Are there other comments or questions about that? I think we're about time to move on to the poll now. Thank you. Did I see any? Okay, no? All right. Okay, we will open the poll for streamlined health insurance carrier contracting process. So the poll is now open for that. Please submit your responses. It was sent at 5:55 p.m. I'm just responding to the it was sent as an updated spreadsheet at 5:55 p.m. yesterday. Thank you.
I see it now.
Okay.
But this was not one of the ones we were able to review yesterday.
Okay. No problem.
So I'm not able to vote on this one either way.
All right, we'll take it as an abstention. Thank you. And I see responses are still coming in. Please continue to vote. The poll will close at 2:26 in a minute. Yeah. Okay. Let us know if we want at least, unless you're abstaining, please try and select one of the options. We want to make sure we have a quorum on that. Would appreciate it. Thank you. Okay, I will now share the screen. We have a quorum because we're yeah. Okay, I will share my screen now, and it looks like a large majority selected the first, which is advanced to slate. So that is going to proceed. Thank you so much, and we will note your abstention. Thank you. All right, I'm gonna stop presenting now. And was that the cannot support, Vanessa? We just want to make sure. Is that the option, the abstention, the cannot support? We want to make sure.
As I mentioned in the chat, I had to abstain because
Abstain.
I'm representing Dr. Kalyana and we did not review this, so he did not review this.
Okay, sorry about that. Yeah, so for the person that selected that they cannot support, if they want to give comments about it so that the coaches can still note that.
Thank you. That was me.
Thank you.
And
okay, yes.
Yes, it's Delegate Bagnall, and again, because I'm concerned about some of what we're seeing with at the national level that's impacting our local level. I'm uncomfortable supporting at this time because we are seeing that having local control but also still having state oversight is benefiting our state at large.
Thank you so much. Thank you for your comment. All righty. Thank you. We'll now I'll stop sharing my screen. It carries on. We'll go to the next one. Please, Shane, proceed with the presentation. Thank you. That will be workforce 012. Just a note that already carried during the last meeting, so we're going to be looking at workforce 13.
And I will note that the workforce work group co-chairs were unable to be here today. So if there are questions, I would recommend that we take action to recommit it to the work group for additional conversation, as unfortunately we don't, I think, have enough folks to really speak to some of the potential details if it's not clear from this. Although we did at the last meeting discuss a number of these.
Just trying to keep us all on our toes here.
Yeah.
I guess. This feels like one more reason to switch to Zoom. All right, let me get this back up.
At least it wasn't me. I really was like,
No,
what did
no,
I
no, no. Sorry about that. They'll get back now. All right.
So as I was saying, we did at least introduce these at the last meeting. However, it was after we lost quorum, so we weren't able to take action on these. So if there are questions, I do recommend that we recommit these to the work group with additional feedback. So this first recommendation is WKF 013. And that is to develop and implement a statewide public health workforce training strategy. The recommendation from the workforce work group is to ensure a well-prepared, effective, and sustainable governmental public health workforce. The legislature should allocate necessary resources and direct the Maryland Department of Health or a new public health workforce commission to develop and implement a comprehensive statewide training strategy focused on upskilling, professional development, and retention of the governmental public health workforce. The strategy should be developed in collaboration with academic institutions, local health departments, and other key partners, and it must align with Maryland's broader public health workforce development goals, such as advancing employee career pathways, addressing emerging public health challenges, and improving job satisfaction and retention. We will now entertain discussion.
Thank you, Shane. And we'll give 2 minutes for that at 2:33. Thanks. Vanessa has a hand raised. Please proceed, Vanessa.
I think this is really nicely written, and I believe possibly those last 3 lines are from our public health workforce development plan. So very appreciative of that. I just want to note the piece here. I think as written, this potentially could be something that would go to the Department of Budget and Management or the MDH HR Training Services Division. And so I don't know if that is the intention, but just kind of wanted to point out that piece here of if the group or if the commission wanted to be a little bit more prescriptive of where and to whom this function is completed by. But in general, very supportive of the concept.
Thank you, Vanessa. Any other comments from our commissioners or their representatives? All right, it's 2:33. We're going to open the poll up. Thank you. Please proceed with submitting your responses. The poll will close at 2:35. Thank you. And if there are any abstentions, please let us know. Thank you. Okay, looks like we have a quorum on that. It looks like it passed. I'll just give it time, 1 more minute. And after that, we will have 1, 2, 3, 4 more recommendations to review after that. Thank you. I can start sharing my screen now since we're nearing time.
Tosin, just for you in the record, I'll note that we do have a quorum of 8. It looks like everyone returned except Jean Drummond.
Okay. All right. And we said quorum. Yeah, it's a quorum. Thank you. All right. Thank you for that. All right. And we have 8 participants on that. So that carries. It's now 2:35. I am going to stop presenting, and majority selected to advance to sleep. Thank you. I will also close the poll. Okay, so the next one is Workforce 014. I'll now please ask Jane to share screen.
The next recommendation is WK014, maintain and strengthen Health Reserve Corps. The Workforce Work Group submitted this recommendation language: provide grants to local health departments to maintain and strengthen Health Reserve Corps to ensure emergency public health response readiness. The legislature should allocate dedicated resources to expand the existing Maryland Response Medical Reserve Corps into a multidisciplinary Maryland Response Health Reserve Corps that more explicitly recruits non-clinical personnel capable of assisting during public health emergencies, disease outbreaks, natural disasters, and other crises that strain the healthcare and public health systems, and supports more robust, locally focused, and trained county-based volunteer corps. A well-supported and operationally ready Health Reserve Corps ensures Maryland can surge skilled personnel rapidly when and where they are most needed.
Thank you, Shane. We'll now entertain questions and discussions about that. It's 2:37, and we'll stop at 2:39. Thank you. Mara, please proceed.
Thank you. So I totally get the concept and agree with it, but I'm trying to understand, is this a fiscal, in essence, a fiscal recommendation? Because we already have a reserve corps that fundamentally does these things. So is this really looking for an expansion or primarily funding to enhance it?
Thank you, Mara. Can somebody from the workforce please speak to that? Maybe one of the workforce members or other people.
From the conversations that I recall between the workforce work group members and co-chairs, it, I believe, was more about creating consistent funding so that it is ready and available on an as-needed basis versus the what I believe was described as a pretty lengthy spin-up process that exists today. But beyond that, if there are more questions, I would have to look to maybe Boris or Vanessa if they recall more of that discussion from those workforce work group meetings.
Apologies, I was not able to attend the meeting on Monday for the workforce work group because of a conflict. And so the first time I saw this recommendation was when you sent it out via email. So I apologize, I don't have any additional information about this.
No worries.
Thank you, Vanessa. Any other thought on that, or any of the work group members want to comment on that? All right, it's 2:39. We're going to go on to the poll. I will open the poll up now. All right, the poll is open for Workforce 014, provide grants to local health agencies to maintain and strengthen Health Reserve Corps. Thank you. We'll close it at 41 to 41. Thank you. Okay, we have one abstention from MDH. All right. Thank you, Vanessa. And I think the reason has been noted, so if we can copy that, please. Thank you. Oh, thank you, Vanessa. All right, it's now time. I will share my screen for the poll. We would include in the poll the number for abstentions, so which makes it a total of 9. So it looks like we have a quorum with 8. So majority selected advance to slate. All right, thank you so much. I'll stop sharing. We'll go on to the next one. I'll have Shane please share Workforce 015. Close the poll. And after that, we'll have 2 more. Thank you.
The next recommendation is WKF 015, strengthen legal protections for public health employees. The workforce work group submits this recommendation language. Strengthen legal protections for public health employees through enhanced penalties for threats, harassment, and acts of violence. The legislature should enact legislation to protect all state and local public health employees and contractors by establishing or strengthening penalties for individuals who threaten, harass, intimidate, stalk, or assault, or otherwise interfere with public health workers in the course of their official duties. This measure is critical to ensure safety of the workforce and the uninterrupted delivery of essential public health services. We will now entertain discussion.
Thank you, Shane. And discussion will end at 2:44. Thank you. And if there are no discussions, that also works. We can advance. We'll just take the queue to see if there are no discussions. But if there's any, or even if you can put it in the chat box. All right, while we're doing that, I will open up the poll, and also noting that you can change your response within the allotted time. So the poll for Workforce, in the interest of our time, Workforce 015 is open. Please submit your responses. legislation should enact legislation to protect all state and local employees and contractors. This will close at 2:46. People time, but if we have quorum, we will proceed. Abstaining, okay, we have one abstention. And if there is additional comments, well, I don't think we received any. If you want to note, please either speak up or put it in the chat box. Thank you. We have a minute. Now we'll close the poll afterwards. At 45. I'll start sharing my screen now. It's time, and the majority selected advance to slate. We have 8 participants plus 1, which is 9, with the 1 abstention. Thank you. I'll stop sharing my screen now. So that moves to the next. The next one is Workforce 016. Shane, please share that on the screen to expand the Maryland Corps to establish a Maryland Public Health Corps pathway. Now we'll stop that poll. And this will be the second to the last of the recommendations for today. Thank you for being with us.
The next recommendation is WKF 016, expand the Maryland Corps. The Workforce Work Group submits this recommendation language. Expand the Maryland Corps to include a public health pathway into governmental public health careers. The legislature should expand the existing Maryland Corps program under the Department of Service and Civic Innovation to include a dedicated public health pathway. This would support a structured service-based entry point into careers within Maryland Department of Health and local health departments. With the direct input of the local health departments, this initiative would build a diverse, skilled, and mission-driven pipeline of future public health professionals equipped to meet the state's evolving health needs. We will now entertain discussion.
Thank you, Shane. And that would cut off at 2:48. Thank you. I will open the poll in the interest of our time. Okay. We have Boris, please.
Yeah, I just wanted to clarify, since this was my question at the last meeting, which is Maryland, just to make sure everybody understands, Maryland Corps is different than the Medical Reserve Corps, right? So I just want to make sure that the commissioners are aware of that that's a separate program. So that's something I learned last time. I want to share my newfound knowledge with others, but chances are everybody already knew that. So
Thank you so much, Boris. Thank you. Thank you. All right, the poll will now be open for Workforce 016. I'm sorry, is that? No, I'm sorry.
Yeah, it's 016.
016, okay, sorry. All right, we open poll, okay. So actually, after this, we have one more, which will be the last for the day. All right, okay, submit my votes. And if there is any abstention, please note that by typing or indicating verbally. Thank you for completing. We'll cut it off at 2:49 to give people enough time. All right, it is time. I'm going to share my screen. Thank you. It looks like no abstention noted. Everyone selected advance the slate. So that goes on to the June 5th slate. All right, I'm going to stop sharing my screen. We'll now review the last one. Shane, please share Workforce 017. Thank you. Which is to establish a public health career pathway program. I'll stop the poll on that. Thank you.
The final recommendation is WKF 017, establish a Maryland-based public health pipeline. This was submitted by the Workforce Work Group, and the recommendation language is to build a strong, diverse, and future-ready public health workforce. The legislature should allocate resources to create a career pipeline that specifically introduces high school and undergraduate students to careers in governmental public health. This program will cultivate early interest, provide hands-on experience, and support the long-term goal of expanding Maryland's public health talent, particularly in underserved and underrepresented regions of the state. We will now entertain discussion.
Thank you, Shane. And that would cut that over to 52. Thank you. Vanessa, please proceed.
I'll just note that I don't believe MDH would support this as written. So we have an existing internship and pathway program, some of which is in the Office of the Deputy Secretary for Public Health Services, and then additional recruitment pipeline and pathway programming through the Department of Budget and Management and the MDH Human Resources. And then, of course, multiple local health departments have their own, local pipeline and pathway program. So I can't see MDH delegating this authority to MHO, but also noting it is a bit duplicative of existing programming.
Thank you, Vanessa. Are there any other comments about that? Well, Workforce 017, establish a public health career pathway program. Maura, please.
Well, I'll just point out that the language isn't very specific about who should establish it. Like, is it the Board of Education for, K through 12 that they introduce in some parts of the curriculum? As far as I know, universities already have it. So with the internship, but to me, that's just wordsmithing.
Thank you, Maura. We'll take one more minute for
So this would be delegated to MHO and specifically.
That's the plan, to delegate this to MHO?
That's as the recommendation reads right now. It says that MHO would create a career pathway program.
Right. Well, okay. Okay. And then I can't support that because MHO does not have the capacity to do that.
Okay, we'll just we'll proceed. We'll open up the votes now. Please make your submissions note using the poll. Thank you. The poll is now open. All right, we'll close the poll at 2:54 in the interest of time so that we can take the other agenda items. Thank you for hanging on. I know it's been a long day, but we appreciate everyone. This takes a lot of investment of your time and efforts. Thank you.
So, Tosin, I just want to point out that this nuance, which is important about MHO, I see it in the poll, but it's not in that first box for recommendation language. So if this does end up moving forward, if we can modify, unless I'm looking at the wrong one again, I think I have the updated one.
The comment is noted for the work group.
Yeah. Dr. Rochester, you're not looking at the wrong information. So what happened here is that METRO component was not specifically included in the recommendation language on that template. However, it does reference that further down on underneath the assessment findings and evidence to support the recommendation. So unfortunately, it looks like that was an oversight related to that language in particular.
Thank you, Shane.
Thank you. The poll will close at 2:55, and then we will wrap the recommendation piece up. Thank you. All right, it's now time. I'm going to share my screen. All right, if there are any abstentions. Okay, I'm going to stop that and share my screen. So we have the majority selecting recommit to work group. Okay, so that carries. Thank you. All right. Now on to the next. Thanks everyone once again. Now on to the next item on the agenda. Shane, do we still have the new business piece? Because it's alluded to in case there was additional recommendations from workforce. Do we still have that piece, or it's covered?
I believe since we're essentially at time and we're about to wrap up, we're probably fine. We added that in case there was time and commissioners wanted to provide some additional feedback. We're happy to take that by email or other outreach if folks want to let us know how the process was working from their perspective or other concerns. And I do see Boris has his hand up.
Sure, thanks.
Yeah, I know we're sort of tough on short on time, but let me sort of be succinct. One is I do like the poll component of this. That makes things move more smoothly. To the commissioners, I also want to say that this voting moves it to the next slight level. So the reality is, at the end of all this, as we sort of have that critical meeting in June, anything that caused you dyspepsia, in essence, can be brought up. We want to make sure that, we're not going to get necessarily consensus on each and every one of these, but there needs to be further discussions where necessary. So, if it's specific wording or specific delegation, I think, Vanessa, you brought up a great point, which is that sense is, can the Maryland Department of Health be, in essence, advocates in their position? And maybe it's got to be reframed a little bit, even by us. So it wasn't moved back to the work group, it was moved on, but that doesn't stop the flow of us making sure that at the end of all this, that we get it right. The next component of this that I wanted to mention to everybody is we are reactionary right now to the working groups providing us their recommendations. They've been working at this for months. They're coming up with what they want. It's not a negative for us to send it back to them because, again, if we have questions, we'd like to have, obviously, the work group leads or representatives on the pertinent meetings so that we can have them discuss them fully, but where necessary, we'll send it back. But also, it doesn't stop us as commissioners from also submitting recommendations from things that we've learned. And I want to sort of put it out there that we aren't just reaction as commissioners. It's not just that we're voting on ideas of others. If you have ideas in any of the functions or even the connecting functions of not work group specific, but just observations on public health, we certainly, we're not going to stop just at the working group levels. For example, even the assessment team that spend time with very many, constituents, right, in terms of all their outreach. I've delegated, Amelia Ria and the team working with Dushanka and others to submit recommendations based upon stuff that they've learned, right? And at the end, I think that's going to make us complete. Over. Thank you.
Thank you. I mean, yeah, wonderful points. Thanks, Boris. Next on the agenda is announcements. Our next meeting will be on May 1st, Thursday, May 1st. It will be hybrid, 2 to 5 p.m. at the Prince George's County Government Building with virtual option, as always. Mina will be presiding the meeting. And following that, we will have additional meetings. Please note those ones as well. May 1st, May 20th, June 5th, July 10th, August 21st, and September 11th. All of these dates are also going to be made available on our website. And I think they're already there. Now, lastly, I would like to entertain a motion to adjourn the meeting. Oh, sorry,
Sorry,
Shane.
Susan, just
Yes,
one thing.
please.
I will echo Boris's feedback.
Yeah.
This, once we found our stride, I feel like this did really work out well, and I appreciate all the commissioners' participation and feedback, particularly for those folks who did have concerns. We will try to reach out to you to make sure that we get that properly, documented and relayed to the work groups. But please feel free to proactively reach out to us or to the work groups as well. You're not prevented from kind of sharing your thoughts and feedback there. So we want to make sure that this process ends up in the right place. So that's just what I wanted to share for those who voted, could not support or recommit. That's certainly still an option.
Thank you, Shane. And even if it's not a work group that you belong, that message will be relayed to the work group co-chairs and then to their members. All right, I would like to entertain a motion to adjourn the meeting. Please.
Motion to adjourn.
Thank you, Maura. Thank you, Delegate Bagno. All right. Can I have vote? All in favor, please say aye.
Aye.
Aye. Okay. Thank you. Any abstention to stay here so we don't end this? I would think not. All right. Thank you so much. And thanks again to our presenter. Thanks to everyone for joining. Have a wonderful day and see you next time. See you on May 1st. Thank you, everyone. Thank you.